Hello, I'm Jared Weiss. I'm a professor of medicine at UNC Lineberger's Comprehensive Cancer Center, and it's a privilege today to be joined by Dr. Sid Sheth, an expert oncologist in head and neck cancer, also at UNC Lineberger Comprehensive Cancer Center. Welcome, Sid.
Thanks so much for having me, Jared.
Traditionally, the dominant causative factor of head and neck cancer was smoking, and number 2 is smoking, and number 3 was smoking. And then very distantly, there were other factors like alcohol. And by alcohol, I mean massive quantities of alcohol, not a few drinks a night kind of alcohol. Uniquely in India, betel nuts. But for really most of the world, cigarettes. And what's changed dramatically is the HPV epidemic. HPV is a virus, and its particular strains that cause cervical cancer, anal cancer, and head and neck cancer. And in fact, this is one of the, might even be the fastest rising cancer in the US, one of the few with rising incidence thanks to that epidemic. Sid, what's different about cancers driven by HPV as opposed to smoking? Why do we care?
Yeah, I think we care because biologically, they're just different cancers. So when we kind of look underneath with the microscope and look under the hood, how they act and how they grow and how they respond to treatment are vastly different. And so thinking about a virus, we know that just the machinery for what makes the virus tick is a little bit less complicated, I would say, than smoking-associated cancer. So it might be slightly easier to target the pathways that are drivers for these cancers. And so we know that across the board, they're more likely to respond to all different modalities that we're throwing at them, which is really exciting from a patient and a physician standpoint.
Yeah. So one thing that might be worth saying very directly is that pretty much every adult has evidence of exposure to HPV. Unless you were raised in a monastery or nunnery from like the age of 2, you've probably been exposed to these, and there's a certain element of bad luck in getting a cancer for it. But if you do, this is not an STD. This does not imply bad behavior of you or one of your partners. This is like omnipresent to an extraordinary extent. And what matters here is not about, that has no implications for testing of a partner or anything like that, because everyone's been exposed to this. The difference is just that we stage them a little bit differently and their prognosis is dramatically better. And as Dr. Sheth very nicely stated, in terms of experimental efforts, there's some unique stuff to target that we're very excited about making advances. So speaking of those advances, I think the first and simplest thing that most of us are talking about is the possibility of decreasing the intensity of our therapy against these cancers because they're so much easier to cure. Sid, what's ready for prime time? What are you considering doing in practice?
Yeah, I think there's so many ways that we can tackle this cancer. And so, at UNC, one of the ways we're approaching it is, can we give lower rates of chemotherapy and radiation therapy? And we've been very successful and happy with the data. But I think looking at 2021, there's really been some exciting studies that have come out, and starting with a cooperative group study, E3311. And so this was really a surgical-based study using TORS or transoral surgery for all patients with what we classify as intermediate risk HPV-associated cancers. And what this study was looking to do was reduce the amount of post-operative radiation therapy. So all patients received TORS up front, and then they were randomized either to 50 gray or 5 weeks of radiation therapy, or 6 weeks and 60 gray, which is a more standard approach. And so these two arms were compared, and really, I think, very exciting to us because we see the side effects, both the acute and chronic toxicities with radiation therapy. There was quite great equivalency between these two therapies. So giving 5 weeks of radiation therapy is just as good, and equally important, there was less toxicity. So this is a huge win for patients who are able to get surgery up front, and now we can de-intensify, giving less radiation overall.
Yeah, I very much agree. Looking at the global landscape, I'm a little more enthusiastic that it's safe to reduce radiation dose than maybe chemo. But yeah, there's a lot of exciting efforts ongoing. Our group has reported on de-escalating all the way to 0 using chemo up front to reduce the risk enough that in some patients to do no adjuvant. And in fact, the study you mentioned, 3311, had some patients that were able to get no radiation at all. And we just accrued the last patient here at our institution together with our collaborators at Vanderbilt and Fox Chase to a study giving chemotherapy and immunotherapy up front to decrease the intensity of what happened subsequently. And I don't know what's happened yet. We haven't tabulated the data, but I look forward to sharing that.
Yeah, and similar to that, there was another exciting study looking at the combination of immunotherapy with chemotherapy out of the Chicago group, so Optima 2. And so they used sister agents to what we did in our study here at UNC, but they used nivolumab with Abraxane and carboplatin. And basically what they did was, based on response to the therapy, they were able to give the same, less, or equal amount of adjuvant therapy. And so what that showed is that these tumors are very responsive to immunotherapy and chemotherapy combination, and the responses and kind of durability or survival for these patients was excellent. So it's just proving that for HPV-associated cancers, we can give really effective therapies and maybe have to do less of the harmful stuff like long radiation or very big surgeries.
Yeah, I was excited about that data. Usually when someone publishes on something similar to what you're doing, you get jealous and bitter, but I was really excited to see this data because it's, to me, really complementary. They treated a low-risk population with HPV positive disease, consistent with the rules of good practice. I haven't tabulated the results of what we did, but the demographics I'm certainly aware of. We accrued a very high-risk population, largely HPV negative, and even those with HPV, a lot of smoking. And so I'm looking forward to having both of these data sets for the respective populations. Anything else to say about definitive therapy or HPV?
Yeah, so we should forget about our friends down under in Australia and New Zealand. So there was the TROG 1201 study, and this compared cisplatin versus cetuximab concurrently with radiation in patients with HPV-associated disease, and once again showed that cisplatin was reign superior and very much mirrors some other larger phase 3 studies that have come out over the past years. So when we're talking to our patients and we're looking at the data, it demonstrates that cisplatin is superior to cetuximab, and there's strong biological reasons too, which we won't get into for this talk, but yeah, just nice to see that there is consistency across different populations across the world, which is great. And I would just add one more thing, Jared, not to get my public health hat on, but I think patients should know and that there is a great vaccine out for HPV, and we would love to be put out of a job if patients can receive this, and we can decrease just the explosion of new cases for oropharynx cancers that are associated to HPV.
Yeah, the HPV vaccine prevents the strains that cause cancer. So I think the companies did an awful job in how they presented this when it first came out. In a puritanical culture, they presented this as preventing an STD. And sure, prevention of STDs is fine, but this is a cancer-preventing vaccine, preventing cervical cancer, anal cancer, head and neck cancer. This vaccine saves lives, and you really can't wait. You have to give it years before the expected time of onset of, let's say, romantic activity is. And if you want to save lives, particularly your children's lives, you have to acknowledge reality as it is, not as you want it to be in the year 2021. My daughters are never gonna, date, but other people's kids are. So jokes aside, jokes, I can't put jokes aside, but everyone really should be vaccinating their children and vaccinating them early. It's very safe, and it could save their life later. And on the side, it prevents STDs, but this is a cancer prevention vaccine. It's very well proven to prevent cervical cancer, combining a little common sense that it prevents the strains that cause head and neck. It's easy to see that it will. And we have some early data that came out, I want to say just pre-pandemic, and has been built upon a little bit since, heavily suggesting that it does just that.
Yeah, absolutely. And I'll just end on this topic saying that this is both males and females are eligible for the vaccine, and there's now even supporting data that it's just not teens and young people, but this could also be effective for older people too. So I think as we learn more about how the vaccine works and also just have more long-term data, I think this could be a really important tool in the toolbox to prevent cancer.